Hello, my name is Wajaha and today we're going to cover BPH. So grab your pen and paper and let's get started. Now the prostate is a small walnut-sized gland that surrounds the urethra which passes through it, as you can see over here. And this picture of a straw going through a donut is a good way to try and imagine how the prostate sits around the urethra. Now BPH is a condition in which the prostate enlarges and it can become so big that it starts to obstruct the urethra itself, so it's no longer patent, and it can even sometimes irritate nearby structures like the bladder. Now, if I break down the word BPH, benign refers to being non-cancerous, and hyperplasia refers to an increase in the number of cells. And in the prostate, there are two: the collagen and the smooth muscle cells. And BPH is very common, and you're likely to see it many times during your career, unless you become a pediatrician or something. And the reason why it's so common is because the prostate continues to grow in the majority of men, and by the age of 50, as you can see, half of men have an enlarged prostate. By the age of 80, this goes to 80%. Now, the hyperplasia is most common in the transitional area of the prostate, which is the innermost part, directly surrounding the urethra. Now, it's because of this BPH is the number one cause of lower urinary symptoms. So I've split these into three main categories. We've got storage, and this refers to a number of different symptoms. We've got urgency, which is having to rush to go to the toilet all of a sudden. Frequency, which is an increased number of times going to urinate. Nocturia, which is having to urinate at night. Now, when you're taking a history, with these patients, make sure you ask about bedwetting too, because that's a sign of chronic urinary retention. Now, secondly, we've got voiding, and this is problems with the stream of urine itself. So it can be weak, can be intermittent, so it stops and starts. There can be hesitancy, which means it takes a while before the urine initially starts to flow. And lastly, we've got post-micturition, which encompasses things that happen after urinating. So these are things like dribbling of urine and the sensation of incomplete emptying. Now, one thing I forgot to add was when taking a history, make sure to check for any underlying conditions like diabetes or multiple sclerosis, which can cause some of these symptoms that we've just covered. Now, just a quick mention on the classification of these symptoms. Usually a questionnaire is given to patients to fill out, and based on that score we can see the severity of the BPH, and this is called the International Prostate Symptom Score. So you can see that a high score, 35, very severe; low score, not so bad. Now, examination wise, we always do a DRE, and we do that to check for the size, which you would expect to be enlarged in BPH. Consistency wise, normal is like that of the thenar muscles in the hand. Nodules could be a sign of cancer, and tenderness a sign of prostatitis. Now, it's important that we do this because sometimes all the other tests can be normal. Obviously, it can be very uncomfortable for the patient, but at the same time, this examination can be the difference between finding something like BPH or something more severe like cancer. It's also good practice to do an abdominal exam focusing on the bladder and external genitalia exam just to see if there are any other causes of the symptoms. Now, moving on to investigations, a urine chart for patients to fill out can show patterns that help to distinguish between the following symptoms that I've written. A urine dip is a good idea to help rule out infections alongside doing bloods like a full blood count and Usinase. Now, PSA, prostate specific antigen, is a blood test that we can do, and it's often raised in BPH. Now, it's important to know that many things can cause this to raise, like cancer, prostatitis, which is infection that can cause a raised PSA for many months. Even doing a DRE, exercise and ejaculation, can cause the PSA value to be raised. Management wise, lifestyle modifications are always first. We try and recommend to reduce the fluid intake, weight loss and exercise. Things like bladder training and double voiding, which is waiting for a while just after urinating to see if they can urinate again, can all help in managing the symptoms. If we move on to the medical side of things, alpha blockers are first line and help by relaxing the smooth muscle that constricts around the urethra. and they improve symptoms in around 70% of men, so they're really quite good. And tamsulosin is just an example of one. Another type of medication that we give is the 5-alpha reductase inhibitors like finasteride. They help to actually shrink the prostate, and sometimes giving a combination of both of these is quite important. For overactive bladders, so men who have urgency and incontinence, antimuscarinics like oxybutynin are a good choice. Now, there's another type of drug called desmopressins, and they can sometimes help to slow down the urine production, so less is produced. Now, if medical management fails to improve these symptoms, then surgery is an option. And the most common type of surgery is called the transurethral resection of the prostate, or the TURP. And it's a surgical procedure that removes part of the prostate. Now, there are a bunch of other surgical options, and to name some of them, we've got the total prostatectomy, which is removing the entire prostate artery embolization, which helps to reduce the blood supply to the prostate and thus shrinks it. We've also got sacral nerve root stimulation, which is like a small electrical device that implants under the skin and sends signals to the bladder for better control. And then water ablation, which is a kind of new treatment involving the use of water at high pressure to break the large prostate into a small size. Now, some of these procedures are relatively new, so I guess the future of urology looks pretty good if you're interested in going down that route. Now, a complication from TURP that comes up in exams quite a lot is called TURP syndrome. And if it comes up in the exam and you see a patient with neurological, respiratory, and systemic symptoms that have just happened straight after the procedure, think TURP syndrome. Now, as always, I've got a mnemonic to help you guys, and today we've got a really good one, and it's just prostate, and that stands for PSA, the rectal exam. Older men who obviously get this condition, we've got the symptoms of storage, voiding post-micturition, tamsulosin, which is the alpha blocker, and then finasteride, the alpha reductase inhibitor, the TURP procedure, and obviously we need to know what it is, of course, and that's an enlarged prostate. There you go. Prostate is the mnemonic. I hope that really helps to remember this all. Right, a few questions now just to end things off. A 62-year-old man presents with nocturia, hesitancy, and terminal dribbling. Prostate exam reveals a moderately enlarged prostate with no irregular features and a well-defined median sulcus. Blood tests show. So that PSA value is actually raised. Now, like I mentioned, the first line medical treatment, alpha 1 antagonist, the alpha blockers. Second question, a 60-year-old man presents with lower urinary tract symptoms and is offered a PSA test. According to NHS guidelines, which one of the following could interfere with the PSA level? So, as I mentioned earlier, there are a number of different things that can cause the PSA value to increase. We've got cancer, prostatitis, even doing a DRE, ejaculation, and exercise. And if you look at all these options, vigorous exercise in the past 48 hours will probably cause the PSA value to go up. Now, a patient is started on finasteride for the treatment of BPH. How long should the patient be told that the treatment may take to be effective? Now, I didn't go through this with you before, but I'll go through it with you now. These medications need to be long-term to be effective. So if you look at these options here, there's only one real long-term option, and that's 6 months. So we need these people to be on their meds for quite a long time. And the last question, a 66-year-old male has just undergone the TURP procedure. The operation notes describe using 1.5% glycine as the irrigation fluid. A prolonged operative time occurred due to the size of the resection required to optimize flow from the gland. The patient has now become agitated, confused, and developed worsening of his breathlessness. You conduct a VBG, which demonstrates the patient to be hyponatremic. What is a likely diagnosis? So we've got neurological symptoms, we've got breathlessness. Just after the TURP procedure, like I mentioned, this is a condition that comes up in exams time and time again. The answer is TURP syndrome. So that's all I wanted to cover today. Thank you very much for listening. Please give a comment about if you have any questions at all. If you want any specific conditions covered in the future, leave a comment. I'll try and get that done for you. And then I'll be back with another video soon. Bye.